Hello? Hello? Okay, no? Hello? Hello? Can you all listen to me? A very good evening, dear students. I'm Dr. Prathyusha and welcome all of you to the second class of Eponyms session. So this is a live YouTube session of the topic Eponyms of nose, pharynx and larynx. So can you all see the video and is the audio clear now? I'm sorry for the technical glitch earlier. I hope everything is clear now. Yes? Okay, that's great. So without any further delay, let me explain the plan for this class. It is divided into 3 sessions. First, let us do the eponyms of nose and then let us do the ones with pharynx and larynx. Okay, and before I actually start the class, there are 2 important announcements. For those of you who are watching this for the first time, the eponyms of ear has already been made. So make sure you go and check out that video after this class is done. And the second point that I want to let all of you know is the notes for this session is available in the Telegram group. And the link to the Telegram group will be placed below the video. So after the session, in a few hours, the notes of this entire class will be uploaded in that channel where you can access them by joining into the Telegram group. Okay. So let us begin. Eponyms of nose. Hi Ashwarya. Hi Dikshita. Hi Vineet Kumar. So this class is for everybody. Those of you who have completed E.n.t. will have a wonderful time and you will enjoy the session, recollecting everything and answering my questions. And those who have just studied it once will also find it useful as a good revision session. And those of you who have never studied E.n.t. will definitely be motivated to open your books after the session. Okay, so let's begin with the eponyms of nose. Screen share. Can you all see what is being written? Now this time, along with the eponym, I would be teaching a little in and around that topic also. Because by far, according to my observation, the eponyms of nose and throat are not very difficult to remember. They're more conceptual that have to be visualized and the entire topic has to be understood, okay? So the first one in our list today is Hasner's valve. What is Hasner's valve? Any clue? Can anybody answer what is Hasner's valve? First category students who are already done with the subject and have just come to the class to revise it. Anybody like that? Very good, Mohammed Saifuddin and Aishwarya. It's nasolacrimal duct. It's not exactly nasolacrimal duct. It's something related to that. Let me explain what that is. So the nasolacrimal duct, as you all know, connects the lacrimal sac with the nasal cavity. Okay. And this nasolacrimal duct opens into the inferior meatus of the nose. The nasolacrimal duct opens into the inferior meatus of the nose. And why is this structure, the nasolacrimal duct, present? When there are excessive secretions in the lacrimal sac, this nasolacrimal duct will drain out all those secretions into the nose. Have you observed this phenomenon that when somebody is crying, their nose also begins to water? It is because of the nasolacrimal duct. All those excessive secretions are being drained into the nose. Okay? But the problem with any connecting structure is communication could be present both ways. It's nice that the nasolacrimal duct drains the lacrimal secretions into the nose. But imagine what if the other way around it goes? If the nasal secretions are all taken into the lacrimal sac, that is something we do not want, right? It has to be avoided. So, to facilitate a one-way communication between the lacrimal sac and the nasal cavity, there is a valve that is present, and that is called as Hasner's valve. Hasner's valve is present at the opening of the nasolacrimal duct in the inferior meatus, and it allows only one-way movement from the duct into the meatus. How much ever the nose is full of secretions, these secretions do not go up via the nasolacrimal duct into the lacrimal sac because of the Hasner's valve. So now we know that this nasolacrimal duct is guarded by a mucosal structure, a mucosal valve that is called as Hasner's valve. Okay. Now, since we are anyhow discussing about the inferior meatus and the structure of the nose, let us quickly recap the other things that open there. The sinuses also open into the meatuses of the nose. The frontal, maxillary and anterior ethmoid sinus open into the middle meatus. Anterior ethmoid, frontal and maxillary sinuses, they open into the middle meatus. The sphenoid and posterior ethmoid, these two sinuses open into the superior meatus. And what is opening into the inferior meatus? It is the nasolacrimal duct. Okay? So is the pace okay? Is everything clear? Can I proceed further? A question to all of you all meanwhile. What is the other name for maxillary sinus? Another name for maxillary sinus, anybody? The pace is okay. Okay, thank you, Aishwarya. I hope you're able to read what is being written on the screen. Waiting for the answer. Another name for maxillary sinus in the eponyms class, what could it be? Wonderful, Dikshita Ravatsu. It is also called as the antrum of Hymor. Another name for maxillary sinus is antrum of Hymor. Very good, Appellite. Okay. So this is all about Hasner's valve. This much I think you should know. Let us move on to the next structure now. And that is, let us discuss a few cells that are present in the sinuses. And they are Haller cell and Onodi cell. Haller cell and Onodi cell. Anybody? Anything about these cells that you know? These are air cells in the sinuses. But why are they important and why do they have specific names? Hi, Amarinder Kumar. The importance of halar cell is that it is situated in the roof of the maxillary sinus. The halar cell is situated in the roof of the maxillary sinus. So what? The importance of halar cell is that due to any reason, most commonly because of infection, if at all the halar cell enlarges in size, enlargement of the halar cell will block the maxillary sinus ostium. It blocks the ostium of maxillary sinus. And when the ostium is blocked, it will lead to maxillary sinusitis. That is the importance of halar cell. Is halar cell clear to all of you? And now let me talk about the Onodi cell. Onodi cell, as Dikshita Rao rightly said, it is present in close proximity to the optic nerve. The Onodi cell is present in close proximity to the optic nerve. That is the sin of Onodi cell, being in close proximity to optic nerve. Why is it a sin? Because anything that happens to the Onodi cell can affect the optic nerve. For example, there are two problems that can occur. One is the infections of Onodi cell can very much travel via the optic nerve. And second is, during surgeries, we have to be very careful not to destroy and injure the optic nerve that is lying in such close proximity. There is just 0.03 millimeters of bone that is separating these two structures. So that is about halar cell and Onodi cell. Okay? Let us move on to the next one in our list, and that is Little's area or Kieselbach's plexus. A very well-known terminology to everybody. What are Little's plexus or Kieselbach's plexus? Hi Shahzaman. What are Little's area or Kieselbach's plexus and why are they important? This is the most common site for epistaxis and that makes this important. Most common site for epistaxis. What is epistaxis? Nasal bleeding. This is the area that's most important for epistaxis. Why? Because four arteries are coming together and anastomosing at that place. And that makes it very prone for bleeds. What are the four arteries? Let us see. The first one is anterior ethmoidal artery. Anterior ethmoidal artery. And the second one is septal branch of superior labial artery. The third one is septal branch of sphenopalatine artery. Sphenopalatine is a very important artery that supplies the nasal septum. In uncontrolled epistaxis, it is the sphenopalatine artery that we try to ligate to control epistaxis. And lastly, septal branch of greater palatine artery. These are the four structures that are present in the Little's area and they are forming a vascular plexus that is called as Kieselbach's plexus. And this is an arterial plexus. So the pressure is high. And where is this located? The Little's area or Kieselbach's plexus is located in the antero-inferior part of nasal septum. Now, why is this important? In the nasal septum, it is present on the antero-inferior part, the part that is most accessible for nose picking. That makes this already vulnerable area more vulnerable to trauma. Its easy accessibility makes it very vulnerable to trauma, mostly by hand picking. And second, this area is also subjected to the drying effects of the inspiratory currents. Now, the air that we inspire makes the nose dry. The humidifying effect is done by the nasal mucosa later on. This area is very vulnerable to the drying effects of the inspiratory air. Firstly, the presence of 4 arteries plus this vulnerable location makes it the most common site for epistaxis. So this is about Little's area or Kieselbach's plexus. Now the epistaxis in this area is the anterior type. It is anterior epistaxis. Very good, all of you, those who have answered. Exactly, Dikshita, except the posterior ethmoid artery, almost all other arteries are participating. The posterior ethmoid artery is not a part of Little's area. In fact, that is how an MCQ will be framed. You will get a question asking which of the following is not a part of Little's area or not a part of Kieselbach's plexus, and the answer is posterior ethmoidal artery. Okay? And yes, this is most common in children. This is responsible for the common nosebleeds in children. Is everything okay? Can I move on to the next topic? Alright, okay. So the next in our list is Woodruff's plexus. After learning about Kieselbach's plexus, let us see what are Woodruff's plexus. And also let us compare and contrast. Kieselbach's plexus are responsible for anterior epistaxis, and these are responsible for posterior epistaxis. Okay? And that was formed by arteries, and this is a plexus of veins. This is the plexus of veins. And our Little's area is present in the anterior end, and this is present at the posterior end. This is present at the posterior end of inferior turbinate. Is Woodruff's plexus clear to all of you? Hi Makin from Bangladesh. You're right, Dikshita. After studying about these two plexus, now let us move on to something else, and that is Cottel's test. Cottel's test. Now I'll tell you what exactly is done in Cottel's test, and you will tell me why it is done, okay? In Cottel's test, the cheek is drawn laterally. The cheek is drawn laterally like this. And why do we do that? And if the nasal airway improves after drawing the cheek laterally, we say that the test is positive. That is Cottel's test. The cheek is drawn laterally And if the airway improves, then the test is said to be positive. Hypertrophy of turbinate, lateral tubercle move, DNS, TNS. All of you are very, very close, but nobody has told the exact correct answer. You're beating around the bush, but I did not get the term that I'm expecting. It's commonly believed to be for DNS, but it is not. It is for nasal obstruction testing. That's a very broad term to say Stastel. It's not for polyp either. Very, very good, Appellite. It is for to check the patency of nasal valve. Okay. Cottel's test checks the patency of the nasal valve. And the test is said to be positive if there is an abnormality of the vestibular component of nasal valve. Abnormality of the nasal valve. What exactly is this nasal valve now? Now, before that, if you all have studied the anatomy of nose, there is something called as the vestibular part. That is the anterior and lowermost part of the nose that is skin lined. Yes? The starting part of the nose is the vestibule. And the upper limit of vestibule is marked by this nasal valve. And the nasal valve is also called as Lyman nasi. The upper limit of the vestibule is marked by nasal valve or Lyman nasi. Okay? And if there is any abnormality of the nasal valve, if it is stenosed, that can be relieved by Cottel's test. Now, all of you have taught DNS because generally this test is not for DNS and it does not relieve the symptoms of DNS also. But when we broaden the airway, patients usually experience a better sense of breathing, at least temporarily. But what exactly we are aiming to check here is the nasal valve. Okay? Is Cottel's test clear to everybody? Next, let us move on to some fractures of the nasal septum. Okay? There are two fractures. One is the Jargeway fracture and next is the Chevalet fracture. If it's a French name, the T would be silent. Chevalet fracture. Okay? There are some common features between both of them and some differences also. The common feature is that both of them are fractures of the nasal septum. Both are fractures of nasal septum. Okay? And both of them occur due to trauma. Okay, generally, any fracture occurs due to trauma. And both of them begin at the anterior nasal spine of the maxilla. That is, at the floor of the nose. The floor of the nose is formed by the maxillary bone. And the maxilla has one anterior nasal spine. And this fracture begins, both of them, they begin from the anterior nasal spine of maxillary bone. These are the common features. Now let us see what are the differences. Jargeway fracture occurs if there is a blow from the front. Blow from front. Chevalet fracture occurs if there is a blow from below. Jargeway runs horizontally backwards. and chevelé runs vertically upwards. Okay. Plus, they both are beginning from the same point, but one is horizontal and the other is vertical, so they do not end at the same point. Gingiva begins at the anterior nasal spine of maxilla, runs horizontally backwards, and ends above the junction of the septal cartilage with vomer. It ends above the junction of septal cartilage with vomer. And where does chevelé end? It begins at the anterior nasal spine, it runs vertically upwards and ends at the junction of the bony and cartilaginous part of the dorsum of the nose. It ends at the junction of bony and cartilaginous parts of dorsum of nose. Now, in the previous class, when we were learning about the 1/3 and 2/3 rules in E.n.t, we have learned that the external nose, the upper 1/3 is made up of bone, the two nasal bones, and the lower 2/3 is made up of cartilage. In the dorsum of the nose, at the junction between the bone and cartilage, this fracture ends. Okay? Is gingiva and chevelé fracture clear to everybody? Now here comes the memory part. How do you remember what is what? I remember J and H as Jharkhand. Gingiva runs horizontally. Okay? And C and V is the other part. If you remember one, you can remember the other one easily. You can just extrapolate. Chevelé runs vertically. Okay? So are these two fractures clear to everybody? Can I move on to the next one? Because I'm anyhow stimulating your memory cells, let me do one more which involves memory. And they are the names of two bacteria. Pharynx bacilli or bacillus and Pharynx bacillus. What are these two names? Anybody ever heard them? Pharynx bacillus and Pharynx bacillus. Now, if I give you their alternative names, you will be able to answer me very quickly. But before that, can you answer where each one of them is seen? I mean, what causes what? Which bacteria causes which disease? Think. Okay, one more clue I can give you. Both of them are Klebsiella species only. Any idea now? I don't know how you take this, but I really enjoy stimulating your memory cells. Okay, too much of wait time. Let me give the answer. Pharynx bacilli is nothing but Klebsiella ozeni. Now tell me what it causes. It causes atrophic rhinitis. Another name for atrophic rhinitis is Oziana. Yes. And first bacillus is Klebsiella rhinoscleromatis. And what does this cause? I need not even tell you, it causes rhinoscleroma. Okay. A few words about each of them now. Atrophic rhinitis. Anything that you can contribute about atrophic rhinitis? What do you all know about atrophic rhinitis? What is the most classical clinical feature that is observed? Merciful anosmia and foul-smelling nasal discharge, plus crusting of the nose. There are a lot of crusts and there is a very foul-smelling nasal discharge, but fortunately for the patient, as a blessing in disguise, he cannot smell his own nasal secretions. So that is merciful anosmia, which is a classical feature of atrophic rhinitis. Okay? And there is an operation, a surgery done for the treatment of atrophic rhinitis. This you must answer. Is everything clear? Why is nobody commenting? All good? Able to understand? Are you with me? At Paris bacillus and Frisch bacillus? There is a surgery that is done in atrophic rhinitis. And I want you to answer that to me. I've explained briefly about atrophic rhinitis, so by now that topic must be running in your mind. The surgery that is done in atrophic rhinitis is Young's surgery and modified Young's surgery, where each of the nasal cavity opening nostril is closed temporarily. It is packed and closed for a few weeks, and later when we open that, all the crusting gets healed. And if it is, if both the nostrils are closed together, it is Young's surgery. If they are closed one after the other, it is modified Young's surgery. So a few words about rhinoscleroma. What do you all know about rhinoscleroma? You're right, Appellite. The surgery is, no, it's not done for turbinate reduction. Sorry, you're not right. Anything about rhinoscleroma? It is a granulomatous disease. Woody hard nose, very good, Aishwarya. That is one classical feature seen in rhinoscleroma. And there are two things that are seen in the histopathology of rhinoscleroma. I'll be very happy if you can answer that. Meanwhile, a little more about rhinoscleroma. There are three stages in rhinoscleroma. Okay, and they are, the first stage is the atrophic stage. This is similar to atrophic rhinitis, where there is foul-smelling nasal discharge. And the second stage is the granulomatous stage. In the granulomatous stage, we find nodules. Painless nodules are seen in the nose, and the last stage is the cicatricial stage. In the cicatricial stage, there is stenosis of the nares and there is distortion of the structures around, and that is the last stage of rhinoscleroma. You're right, Dikshita. Rhinoscleroma, Klebsiella rhinoscleromatis cannot be cultured. There is something that you can see in the histopathology. If you take a biopsy specimen of the nodule, you can see some very classical structures. Can anybody name what they are? Two types of very good Appellite Mikulicz cells. And there's one more. There's one more along with Mikulicz cells. What are they? I can take that as the next one in our list actually. Micolic cells and Russell bodies. Yes, you're right, Vikas Jadhav, it is Russell bodies. These two are seen in the histopathological examination of rhinoscleroma. What are Micolic cells? They are large foam cells with a central nucleus and vacuolated cytoplasm. They are large foam cells with central nucleus and vacuolated cytoplasm. It's actually easy to identify Micolic cells on a slide. Okay. And what are Russell bodies? Now, Russell bodies are seen in some other condition also. Not E.n.t, but nevertheless you can answer it. Russell bodies are eosinophilic inclusion bodies that are found in plasma cells. They are eosinophilic inclusion bodies found in plasma cells. What are they exactly? They are accumulation of immunoglobulins. Very, very good, Aishwarya, for the first answer. They are also seen in multiple myeloma. Russell bodies are seen in multiple myeloma. They are accumulation of immunoglobulins basically. Okay. So I hope you have understood about rhinoscleroma also briefly. What are the three stages? Atrophic stage, granulomatous stage and cicatricial stage. Okay. Can I move on to the next one? The next is not an eponym, it is just a sign that is seen, and that is reservoir sign. Where is it seen and what is it? Reservoir sign is seen in two places in E.n.t. I'm going to discuss one here, and that is about CSF rhinorrhea. And the other is correctly answered by Vikas Jadhav. It is seen in acute mastoiditis. Not in AOM apelite, it is seen in acute mastoiditis where the secretions are continuously coming in the ear. And that is an indication for cortical mastoidectomy, uncontrollable secretions, as if there is a reservoir of fluid that is present inside. That is one condition that is seen in acute mastoiditis, and reservoir sign is also seen in CSF rhinorrhea. What is CSF rhinorrhea and the reservoir sign? It is a clear watery discharge. In CSF rhinorrhea, what you see is clear watery discharge that is profuse. It's profusely coming out of the nose, from the nose, obviously, because it is a rhinorrhea. And it is more so on bending. When the patient wakes up in the morning and if he puts the head down while bending the head, or even during straining, this clear watery discharge comes out. And how is the watery discharge? It is a sudden gush of fluid. It is very profuse. Sudden gush that cannot even be sniffed back. That can't be sniffed back. Now, sometimes we have profuse secretions even in common cold. But those secretions can at least minimally be sniffed back. If we do not have a hanky or tissue in hand, at least for some time it can be sniffed back, but CSF rhinorrhea just cannot be sniffed back. It's like somebody has opened the tap uncontrollably and all the fluid is coming out. That is classically seen in CSF rhinorrhea and it is called as reservoir sign. Now, all other discharges, even the discharge of allergic rhinitis can be sniffed back, but this cannot be sniffed back. And why does CSF rhinorrhea occur? It occurs because of leakage of CSF into the nose. Leakage of CSF into nose. And since we are anyhow discussing about CSF rhinorrhea, let us discuss two more important signs that are related to CSF rhinorrhea. One is if CSF rhinorrhea occurs because of a head trauma, then there will be some amount of blood also in this discharge. It is a blood-stained discharge where the CSF mixes with blood, and this happens when CSF rhinorrhea occurs due to a head trauma. And in such cases, we find another classical sign. What is that called as? It is called as the halo sign or the double target sign. Very, very good, Dr. Divya and Vikas. It is the halo sign or the double target sign. There are two things. In the center, there is a central red spot and a halo surrounding it. The central red spot is because of blood, and the halo that surrounds it is because of CSF. Okay. Now, I'll just tell one more point about CSF rhinorrhea and end this. CSF rhinorrhea, not the session, okay? What is one very sensitive and specific test for CSF rhinorrhea? Like after you take the fluid and send it to lab, a biochemical lab, they search for one substance which is very, very sensitive, which is very, very specific to CSF rhinorrhea, and it is also a sensitive test. Now, that substance is not seen in nasal discharge. It is only seen in CSF. What is that substance is the question. Anybody quickly? It is beta-2 transferrin. It is beta-2 transferrin. This is an MCQ. It is sensitive and specific to CSF. It is absent, not found in nasal discharge. Okay, beta-2 transferrin. So, what are the important things that we discussed about CSF rhinorrhea? One is the reservoir sign. Second is the halo or double target sign, and then the beta-2 transferrin. All of them are questions. Okay. Can I move on to the next one? The next topic? And that is Killian's polyp. What is Killian's polyp? Anybody? What is a nasal polyp in the first place? A nasal polyp is a non-neoplastic mass of edematous tissue that is found in the nose. It is not neoplastic and it is edematous. Now, a polyp does not bleed on touch. It is not a vascular structure. It is not painful. There is not much nerve supply to the polyp. Okay, it's painless and it is bloodless. It does not bleed on examination. That is a nasal polyp. And there are two kinds of nasal polyps. One of them is Killian's polyp. What is Killian's polyp? The two nasal polyps are, one of them is antrochoanal polyp And the next one is ethmoidal polyp. One of them has an eponym, which is Killian's polyp, and you have to answer me what is that. Now, Killian, if you change the I to A, Kalyan is a very common Indian name. With due respect to the scientist, I am changing this Ki to Ka to make it Kalyan and make it very indigenous to all of you. And why am I doing this? A for A. Killian's polyp is antrochoanal polyp. Okay? That's how you can remember. Another name for antrochoanal polyp is Killian's polyp. Let us discuss a little about these two polyps. Apart from the memory aspect, let's dive a little into these two polyps. Antrochoanal polyp is common in children. Whereas ethmoidal polyp is common in adults. The cause or reason for antrochoanal polyp is allergy plus infections. Ethmoidal polyp, the main reason is allergy. Antrochoanal polyp is unilateral, whereas ethmoidal polyp is bilateral. Antrochoanal polyp is single, it is solitary. Ethmoidal polyps are multiple. Okay? An antrochoanal polyp appears pale, whereas this is smooth and glistening, shiny. Okay? Any more differences? How does an antrochoanal polyp look? It is trilobed. There are three parts: the antral part, the nasal part, and the choanal part. Whereas ethmoidal polyps are small, they look like grape-like masses. Small grape-like masses. And upon surgery, after the surgery, if the surgery is properly done, the recurrence is uncommon for antrochoanal polyp, whereas recurrence is common for ethmoidal polyp. These are a few differences between antrochoanal polyp and ethmoidal polyp. Okay? Are you able to revise that lesson? That is my idea of the session actually, so that we are running through the entire chapter of nose in the name of eponyms. Okay? We are also making base to remember, plus we are learning something around that topic. Hi Xavier Gandu, I hope I've pronounced your name properly. Hi Rashid. Okay, let's move on to the next one now. Can I move on, or do you want me to say anything more about polyps? I think we've done it in detail with all the differences. Okay, the next one is Samter's triad. Now, Samter's triad is a very interesting condition, and it has become all the more interesting because of its recent appearance in so many entrance exams. It's being repeatedly asked in exams. So, upcoming aspirants for fmge exam, aspirants for the upcoming fmge exam, please keep Samter's triad in mind. So, there are three features in Samter's triad. One of them is nasal polyp. The second one is bronchial asthma. And the last and most important one is aspirin sensitivity. Okay, yes. Most of you have answered it rightly. Very good, Divya, Dikshita and Black Pearl. This is the triad. Now, this appears very simple here. It's just nasal polyp, bronchial asthma, aspirin sensitivity. But this will be asked in terms of a clinical scenario. Now, sometimes they could directly tell you that the patient is a known case of Samter's triad and he comes to you with fever or some pain. What is the drug that you must not prescribe? Okay, and aspirin will be the answer, one of the options, and that is the answer. Or in another way, they could give you a clinical scenario where they say the patient is having a nasal polyp and episodes of asthma, and they can ask you about aspirin sensitivity, or they can even mention something like a nasal polyp patient history of asthma and some drug has been prescribed and now the patient has come with the reaction, adverse effect of that drug. Why did that happen? What could be the reason? Because of Samter's triad. Like that, in multiple ways this question can be framed, and I feel that is the reason why it's being repeatedly asked. Okay, but there's nothing very difficult about Samter's triad. Okay, alright. Next, let us learn about Cartagener's syndrome. Cartagener's syndrome. Cartagener's syndrome also consists of multiple things. Black Pearl, you're wrong. You have to pay attention here. There are two very similar syndromes and I will tell you, I will explain. In Cartagener's syndrome, what you find is bronchiectasis, sinusitis, chronic sinusitis, situs inversus, that is dextrocardia, and the basic pathophysiology is ciliary dyskinesia, ciliary dyskinesis. The dynean arms of cilia are not functioning properly and that is leading to this bronchiectasis, sinusitis and situs inversus. Why situs inversus will occur in ciliary dysmotility? Can anybody explain? It's very conceptual and interesting. Now, during the embryologic period, the heart undergoes rotation, and for the rotation of any structure, cilia play a very important role. And because in this patient, the cilia are immotile, the dynean arms are genetically affected, they are mutated. So even in the fetal life, they are not functioning properly and that will prevent the normal rotation of the heart. And so the patient will have dextrocardia. That is the reason for dextrocardia in Cartagener's syndrome. Okay, is Cartagener's syndrome clear to everybody? Now, many people will also add infertility in Cartagener's syndrome. Infertility could be there, but it is not definitely seen in Cartagener's syndrome. Why? Cartagener's syndrome does not cause infertility in females. It causes infertility only in males. It causes azoospermia. The ciliary problem will cause azoospermia only in males. And we have another syndrome for that, and that is called as Young syndrome. In Young syndrome, what we observe is sinopulmonary disease. The lungs and sinuses are affected. Plus, here there is infertility. Now, if infertility is given in the question, to be more precise, azoospermia. If this is given in the question And if unfortunately both Carter-Jenner's and Young syndrome are given in the option, you have to opt for Young's syndrome. Is this clear to everybody? You have to opt for Young's syndrome if both Carter-Jenner's and Young are present. Azoospermia in Young's syndrome. Now there is a lot of confusion regarding this concept, but please make it clear once and for all. Many people use these terms interchangeably, but there is difference between Carter-Jenner's and Young's. Now another challenge for all of us is how to remember. Even if we have understood that they both are different and if infertility is specific to Young syndrome, how to remember who are bothered about infertility mostly? It is the young people. Children and aged people are anyhow not bothered. It is only the young age group who is bothered about infertility. So Young syndrome, go with infertility and azoospermia. Is this clear to everybody? Can we really see dextrocardia in our regular hospitals? Yes, Deekshita, we can see, and in fact I have seen, and there's been a very funny encounter when I was a medical student and I was trying to auscultate for the patient, and I put my stethoscope on the mitral area, and for a long time I couldn't hear anything, and the patient was a case of dextrocardia, and the patient knew he was dextrocardiac. So then he told, my heart is on the right side, madam, do not put your steth on the left side. And then when I actually put the steth on the right side, I could hear the heartbeats very clearly. And yeah, I have seen a case of dextrocardia, and patients of dextrocardia sometimes know that they are dextrocardiac, and they even tell us that their heart is on the right side. Okay. So is Carter-Jenner's and Young syndrome clear to everybody? Let me move on to the next one, and that is Church-Strauss syndrome. Okay. What all do we see in Church-Strauss syndrome? Anybody? It's a syndrome with, any syndrome would have multiple entities. So what all do you see in Church-Strauss syndrome? One answer, eosinophilia. Yes, you're correct, Deekshita. We see asthma. We see eosinophilia, as Deekshita has answered. We see vasculitis, granuloma, plus fever. These are all part of Church-Strauss syndrome. Okay. Now, when I was learning about asthma, I always remembered as two C's. One is Church-Strauss syndrome, and the other C that is related to asthma is Kurtzman spirals that you see. Is anybody able to recollect Kurtzman spirals that are seen in asthmatic patients? Okay, so this is about Church-Strauss syndrome. And the next one in our list is tripod fracture. This is the third fracture that we are learning in this session. What were the previous two? Jarjave and Chevalet. Very good, Deekshita. The third C is Crayola bodies. Actually, yeah, three C's. Church-Strauss, Kurtzman, and Crayola bodies also. Okay, what about tripod fracture and the other two fractures that we have learned? Jarjave runs JH, Jharkhand, horizontal, and Chevalet runs vertical. Okay. And third fracture that we are going to learn is tripod fracture, and this is a fracture of the zygomatic bone. It's a zygomatic bone fracture. And as the word suggests, tripod. Now this is also not an eponym. I've just put here because it is slightly memory based, okay? And we see the fracture at 3 places. What are the 3 places? One is at the zygomatico-temporal junction, zygomatico-temporal area, this is one. At the junction of the frontal bone and zygomatic bone, zygomatico-frontal fracture and infraorbital fracture. Now this is the zygomatic bone. Zygomatic bone is responsible for the malar eminence that we see, the cheekbone we call, okay? Now there is one connection it has with the frontal bone, there it is fractured, and it has one connection with the temporal bone, there also it is fractured, and it's in the infraorbital area also it is fractured. So 1, 2 and 3, that is the tripod fracture. And what are the clinical features that we see in tripod fracture? There is flattening of the cheek. I'll write all of them for you because tripod fracture could actually be a question. I mean, it can be a question in a theory exam as well as in an MCQ exam. So let me write the features for you. As I told you, zygoma is the bone that is responsible for the cheek eminence. So when that bone is fractured, there will be flattening of cheeks. There is anesthesia in the cheek area. Why should there be anesthesia of cheek area? That area is supplied by infraorbital nerve. And in zygomatic injury, zygomatic fracture, that nerve is injured. It's commonly injured because of injury to infraorbital nerve. Okay. Other features that we observe are periorbital emphysema, due to the trauma, emphysema occurs. Step deformity. Step deformity of the lateral orbital rim. This occurs because of the zygomatico-temporal fracture. Trismus is also observed. What is trismus? Not Christmas, trismus. Trismus is locked jaw. And why should the jaw be locked in a zygomatic fracture? Anybody, any clue? Because of the depression. Now after the zygomatic bone has lost its 2 connections, it will fall down. Okay, there is a depression. Fall down in the sense, not like falling down to gravity. It drops down, it is depressed. And because of this depression of zygoma, and what is present underlying here is the mandibular bone. Due to depression of the zygoma on the underlying coronoid process of mandibular bone, trismus occurs. All the sensitive structures here are disturbed, and that leads to trismus. Is it clear? And then diplopia is observed. Double vision occurs. Why does diplopia occur? Due to entrapment of inferior rectus muscle. When the inferior rectus muscle is entrapped, the ocular movements are restricted. And these restricted ocular movements lead to diplopia. Is it clear? Plus, one last feature, the palpebral fissures become oblique. oblique palpebral fissures. These are all the features that are seen in tripod fracture. Now first you should be able to remember that tripod fracture is a fracture of the zygomatic bone, and then all these clinical features will slowly come one by one. Okay. Can I move on to the next one? After zygoma, let us learn about one more fracture in the same area, and that is Le Fort fracture. There are three types of Le Fort fractures, and they are Le Fort 1, Le Fort 2 and Le Fort 3. Okay? And they are all fractures of maxillary bone. Fractures of maxilla. Le Fort 1 is a transverse fracture. Okay? This occurs above and parallel to the palate. Above and parallel to palate. Le Fort 2 is a pyramidal fracture. And what are the structures this involves? It involves the root of the nose. This is the root of the nose, okay? Root of the nose, lacrimal bones. The lacrimal bones are also present there only. The floor of orbit, the upper part of maxillary sinus, and pterygoid plates. These are the structures that are involved in type 2, Le Fort 2 fracture of maxilla. And finally, there is the third variety, and that is craniofacial disjunction. What does it mean? What does craniofacial disjunction mean? The facial bones are completely separated from the cranial bones. Now, Le Fort type 3, Le Fort 3 is very, very dangerous. There is complete separation of the facial bones from the skull bones, the cranial bones. This also involves the root of the nose plus the ethmofrontal junction, superior orbital fissure, the lateral walls of orbit, frontozygomatic and temporozygomatic sutures plus the upper part of pterygoid plates. So this is about Le Fort fracture, which is fracture of maxilla. What you must remember is there are three types. One is here, it is transverse at the level of palate. 2 is above, it is pyramidal, and 3 is totally above, where there is complete craniofacial disjunction. Is a Le Fort fracture of maxilla clear to everybody? Can I move on to the next one? Please give a quick thumbs up if everything is okay. All right. The next one is Pott's puffy tumor. What is Pott's puffy tumor? This occurs as a complication of frontal sinusitis. It is osteomyelitis of the frontal bone. And why does osteomyelitis occur in the frontal bone? As a complication of sinusitis. Okay, very good. You're right, Dikshita. It occurs as a complication of sinusitis in the frontal bone. Now, pus could be present externally or internally, and if it is present externally as a subperiosteal abscess, that is, pus may form externally under the periosteum as a soft, duffy swelling. Soft, duffy swelling. And this swelling is called as Pott's puffy tumor. And this is a potential MCQ question. Okay. Where is another place where you listen to the word pot? Orthopedics? Can anybody answer? I'll move on to the next one. Meanwhile, you'll keep answering if anybody knows anything else about pots. Okay. The next one on our list is Ringer's tumor. Ringer's tumor is also called as Schneiderian papilloma. It is called as Schneiderian papilloma. It's also called as inverted papilloma. Also called as transitional cell papilloma. Now looks like we will get exhausted by the time we learn its names only. Very, very good. Pott's spine that is seen in TB. Good, Aishwarya, Vikas and Stastel. Pott's spine seen in TB. Okay. So, Ringer's tumor, inverted papilloma, Schneiderian papilloma and transitional cell papilloma, all of them mean the same. Basically, it's a benign tumor of the non-olfactory mucosa of the nose and paranasal sinuses. What is Ringer's tumor? It is a benign tumor of non-olfactory mucosa of nose and paranasal sinuses. And the most common site of origin of this tumor is in the middle meatus. A quick recap, what are the sinuses that open into the middle meatus? Frontal sinus, maxillary sinus and anterior ethmoid. Okay. So, Ringer's tumor also most commonly originates from the middle meatus. And although it is a benign tumor, it is locally invasive. And another problem with this Ringer's tumor is it is misdiagnosed as a polyp. It looks a little similar to the antrochoinal polyp. So, it is misdiagnosed as a polyp. These are some of the features. Yes, Desingo Pradip, it is benign but locally invasive. And another feature is it's thought to be caused by the human papilloma virus. Now, why is it called papilloma? Is it because it is caused by HPV? No, not because it is caused by human papilloma virus. It's called Schneiderian papilloma or inverted papilloma because when you look at the histopathological slide of this tumor, you will find papillae. You will find papillomas. Okay. So, this is about Ringer's tumor. This is also a very important question actually. In a theory exam, this question is important and it's commonly known as inverted papilloma. I'm sure everybody must have heard and learnt about inverted papilloma, But I don't know how far you know that it is also called as Ringer's tumor and Schneiderian papilloma. It's called Schneiderian papilloma because the epithelium that is lining the nose, the non-olfactory epithelium, is called as Schneiderian's epithelium. Now, Schneiderian's epithelium is the name for the epithelium lining the nose. And you will be surprised that this has been once asked in NEET UG as a question. Okay, not papilloma. What is the epithelium lining the nose? And the answer is Schneiderian epithelium. And because of that, this tumor is called as Schneiderian papilloma. Okay. So is Ringer's tumor clear to everybody? Can I move on to the next one? Okay, I have a question to ask all of you. Now, this is the tumor of the non-olfactory mucosa. What is the tumor of olfactory mucosa? I will wait for your answer, and meanwhile I will do the next one, okay? So the next one is Orngrens classification. What is Orngrens classification and where is it used? Now, basic information that you must know is where is it used at least, okay? It is used in the carcinoma of maxillary sinus. There are various classifications for maxillary sinus and this Orngrens classification is one. And what makes Orngrens classification important is it gives us the prognosis of the carcinoma. How can it give the prognosis? And what exactly is Orngrens classification? Orngrens classification is a line. It is an imaginary line that extends between the medial canthus of the eye from here to the angle of mandible. This is the angle of mandible. This is the line. It is an imaginary line, imaginary plane extending from the medial canthus of eye to angle of mandible. Now, anything above this line has a bad prognosis compared to the one below the line. That is the location of the tumor I am talking about. Now, if the maxillary carcinoma is below the line, it has better prognosis than the one which is above this imaginary line. Okay. So, if this is the line from the eye to the angle of mandible, this area has good prognosis and this area has bad prognosis. Or is it the opposite way around? This area has bad prognosis and this area has good prognosis. How to remember this? How to remember which area has good and which is bad, poor prognosis and good prognosis? What if you do this in the exam, like the way I did now? Up is better, below is poor, no, up is poor, below is better. These things must not happen. See, logically, if you try to think, it's very easy and obvious. Now, all the vital structures, such as the brain and the cranial cavity, are present in this area. Yes or no? What is present here? We only have the nose and oral cavity structures. What are more important? Structures in the cranial cavity. So, a tumor that is closer to the cranial cavity will obviously have a bad prognosis. Now, as long as you try to memorize such things, They will always remain as confusions. If you try to figure out a way, that was the moral of the entire previous class also, eponyms of ear, right? If you try to figure out a way to learn, it will always stay. And this is a very reasonable logical answer. Now, because the tumor is in close contact with vital structures, a tumor in that area will have bad prognosis. It will have a poor prognosis. Okay. Is this clear to everybody about Orngrens classification? The imaginary line and structures above and below. Meanwhile, very good, Desingu Pradeep. It is esthesioneuroblastoma. What is esthesioneuroblastoma? The tumor of the olfactory mucosa. Esthesioneuroblastoma. The tumor of non-olfactory mucosa is Ringer's tumor, while that of the olfactory mucosa is esthesioneuroblastoma. It's not olfactory neuroblastoma, Pallav Kumar. It's esthesioneuroblastoma. That is the answer I was expecting. Now, because we are anyhow discussing about the maxillary carcinoma, let me talk about one more type of classification that is used, and that is the Lederman's classification. Lederman's classification does not give you any prognosis, or it does not have any significance. This just helps you in locating the tumor. This is used to classify maxillary carcinomas. How does it help you in locating the tumor? Lederman has given two lines, two imaginary lines of Septal. Two imaginary lines of Septal. They are two horizontal lines like this, okay? And one line runs at the floor of orbits, and the second line runs at the floor of antrum. Okay, these two lines will divide the entire area into three zones, 1, 2, 3. Now you can describe in which area the tumor is, zone 1, zone 2, zone 3. That is all about Lederman's classification. Now, for all practical purposes, Orngrens classification is more important to us because that will give you prognosis. Is it clear to everybody? Okay. Next in my list is something called as Kallmann syndrome. Kallmann syndrome. What is Kallmann syndrome? There are two things in Kallmann syndrome, and they are congenital hypogonadism plus anosmia. Very good, Desingu Pradeep, anosmia. Now, questions pertaining to Kallmann syndrome are more asked from an OBG point of view. Okay, when they're discussing about hypogonadotropic hypogonadism, hypergonadotropic hypogonadism and all those things, questions pertaining to Kallmann syndrome will be asked while learning about primary amenorrhea and all those things. Why I'm discussing it from an E.n.t. point of view is, if you find anosmia in such clinical scenario, it's almost straightly pointing towards Kallmann syndrome. Okay. Yes, you see in cases of primary amenorrhea. So this is about Kallmann's syndrome. Next is something called as Sluder's neuralgia. What is Sluder's neuralgia? It is a neuralgic pain that is seen in the lower half of the face. Neuralgic pain in lower half of face with the pain radiating The pain is in the lower half of face, but it radiates to the orbits, temples, these areas, forehead, and sometimes even to the teeth. Along with pain, there is nasal congestion, rhinorrhea, and increased lacrimation. These are the features of Fludder's neuralgia. Is this clear to everybody? Now I will complete nose with one of the most important eponyms in nose, and they are the X-ray views of paranasal sinuses. Yes? These are very, very, very important, and with this we will complete nose. Okay? Let us study the 4 views. First one is Waters view, the most commonly done view. Waters view, what is the position? Occipitomental. Occipitomental. That is the nose-chin position. And which sinus is best visualized in Waters view? Maxillary sinus. You can also see frontal and ethmoidal sinuses and sphenoid sinus also if Waters view is taken with an open mouth. But best visualization for maxillary sinus can be seen in Waters view. Is that okay? And the next one after Waters view is Caldwell's view. That is occipitofrontal view. Occipitofrontal position. Nose forehead position. The sinus that is best visualized in this view is frontal sinus. Next we have the Hid's view. What is the position here? It is submento-vertical position. Submento-vertical. And what is the sinus that is best appreciated here? It is the sphenoid sinus. And finally, Ricci view. Ricci view, the position is lateral oblique. And this is for the one that is remaining, and that is ethmoid sinus. Okay. So are these views clear to everybody? But the point is how to remember. Yes? Okay. Let's figure out a way. W, if you reverse, what will it become? If you make it upside down, W becomes M. Yes, M for maxillary sinus. Caldwell view, what is that view? Occipitofrontal view. Now, why are you putting the forehead like this and taking an X-ray? Because you want to see the frontal sinus that is located close to the forehead. Okay. Frontal view for frontal sinus, occipitofrontal view for frontal sinus. Now, some people will say, ma'am, I should remember that Caldwell's view is occipitofrontal. No, if I remember if it is occipitofrontal, then frontal sinus can be visualized fine. But how to remember Caldwell's view is same as occipitofrontal? Okay, now for such things, I have another mnemonic which says, coming first in high school, or I came first in high school, and raised expectations. Now, even if a kid is very, very smart, until they come in first class in the high school, usually in primary and middle school, even if they're performing well, nobody bothers. Once in high school, if they come first, their expectations for the entire life will raise. That's the mnemonic. What does it mean? C for Caldwell, F for frontal, H for Hitz, S for sphenoid, R for Risi, E for ethmoid. Can you all remember the names now? Can you all remember the names? Okay. So with this, we finish the eponyms of nose. I will briefly revise all of them, not all of them, few of them with certain pictures. Okay. I will show you the picture and you have to tell me what that is. I will briefly label them. This will serve as a revision and also it will be a quick recap. Fine. I promise to be quick. And after this, you will get a break. Okay. What are you seeing here? What is this picture depicting? Little's area. This is Little's area. The only artery that doesn't participate here is the posterior ethmoid artery. I have another picture showing the same. This is also about Little's area. Here the vascular plexus occurs. Okay. What is the test that you're seeing here? What is being performed? Dr. Rahul, all the sinuses are seen in water's view, but best visualized is maxillary sinus. You can also see sphenoid if the mouth is open, water's view with an open mouth. Okay. Yes, all of you correct. This is Cottel's test. The cheek is being pulled laterally to check for nasal valve. What fracture is this? It's running horizontally. And when will a fracture run horizontally? When there is a blow from the front. What is that? What's that? Be quick. No, Dr. Rahul. We are not talking about maxillary fracture. This is a fracture of the nasal septum. This is a fracture of nasal septum. Yes, Tesingo, you're right. This is Jarjave's fracture. And the next one below, which is running vertically, is, needless to say, Chevalet. Okay. Good, Aishwarya, and good, Black Pearl, correct. What are the cells that you're seeing here? What are the cells seen here? Foamy cells. Microlegs cells, very good. Microlegs cells. Where are they seen? Rhinoscleroma. This is also a histopathological picture of rhinoscleroma, both of them, this and this. Okay. What is the sign that is seen here? What is this? Very good. It is the double target sign, also called as halo sign. And where is it seen? Not just CSF, yes, very, very good, Desingu Pradap. It is traumatic CSF, rhinorrhea, traumatic CSF rhinorrhea. The center part, this is because of the blood, and the halo surrounding, this is because of the CSF. Okay? What is this that you're seeing here? What is this picture? This is also the double target or halo sign, but what you're seeing here is CSF otoria. Now there also, if the CSF mixes with blood, you will see a double target sign, okay? The concept is whenever CSF mixes with blood and if it leaks like this on a filter paper, you can see the target sign, be it CSF rhinorrhea or CSF otoria. For that purpose, I've put this picture, okay? Alright. What are you seeing here? What are these structures? Be quick. Yes, yes. Polyp. Which polyp? Which polyp? No, it's not inverted papilloma, Desingu Pradap. You're seeing multiple polyps there. They are ethmoidal polyps. Grape-like structures. Yes, correct, Aishwarya. Very good. Now, I'm going to show you 3 pictures. You have to tell me what each one of them is. They are the maxillary fractures. Le Fort 1, which is transverse, 2, which is pyramidal, and 3 is craniofacial disjunction. Are you able to understand the maxillary fractures very clearly now? This is the transverse one that runs at the level of the palate, and this is the pyramidal one which is involving the root of the nose, and this is complete craniofacial disjunction. Is this clear to everybody? Okay. And finally, what is this picture? Just a second. Yeah. What is this? This is inverted papilloma, also called as Ringer's tumor. Okay. Now, all of you all take a quick break for 5 minutes. Drink some water, take some refreshments, and come back with more energy. Let us do the eponyms of pharynx and larynx in the next session. Now, I promise you there are very few in pharynx and larynx, and most of them are very well known to you. It will just be a quick and good revision, okay? But I can tell you the eponyms of pharynx are by far the most important ones, okay? So make sure you do not miss the session. Just take a quick 5-minute break and come back, all of you. Mute-lone unnano. Mute-lone unnano. Welcome back, all of you. Let's begin with pharynx. Is the audio and video clear? Thank you, Eponyms, for your kind word of appreciation. So, is the audio and video clear? Did everybody come back? Okay. Yes. Okay. All good. Let us start with eponyms of pharynx. And the first one that we are going to look into is Killian's dehiscence. Killian's dehiscence. Okay, hi, welcome back Desingu. Hi Priyanka Rachapalli and welcome back Dikshita. What is Killian's dehiscence? Where did we come across the word Killian already in our class? First answer that. We have already heard this name before. Quickly. Polyp. Very good. Okay. Which polyp? Which polyp? Don't be lazy, Dikshita and Aishwarya. Answer it completely. Which polyp? Now I gave you a memory tip also, so you can't afford to forget. We very kindly changed the name of Killian to Kalyan for our convenience. Yes, antrochoinal polyp. Okay, very good. So now let's look into Killian's dehiscence. Now there are two muscles, there are two parts of the inferior constrictor muscle, okay? One is the thyropharyngeus and second is the cricopharyngeus. Thyropharyngeus is oblique like that and cricopharyngeus is horizontal, yes? In between these two parts, there is a potential gap and that gap is called as Killian's dehiscence. The potential gap between thyropharyngeus and cricopharyngeus. What are these two? They are two parts of inferior constrictor muscle. In between these two, there is a small gap, a potential gap, and that is called as Killian's dehiscence. Okay? And why is a dehiscence important? For two reasons. One, through this gap, perforation can occur during an esophagoscopy. Perforation during esophagoscopy. The second one, all of you know. What is that? It is the site for herniation of pharyngeal mucosa. And what is that herniation called as? As most of you have answered, it is, what is that herniation called as? Now there can't be a question simpler than this. Very good. Zenker's diverticulum. Killian's dehiscence is important for these two reasons. Through that small space and gap, the pharyngeal mucosa can herniate outside as Zenker's diverticulum. Plus, that is the site where perforation occurs during an esophagoscopy. This is why we have to learn Killian's dehiscence. Now, for every point, I'm usually telling this, why should we learn? Because the human mind remembers only those things which it considers important. Okay, so you should have a reason for remembering everything. That will enhance and boost up memory. Let us, because anyhow we have taken the word Zenker's diverticulum, let's talk a little about Zenker's diverticulum. It's a Pulsion diverticulum. Okay. Zenker's diverticulum is a Pulsion diverticulum. And it is a false diverticulum. Why is it called a false diverticulum? Anybody? Because all the layers are not present in Zenker's diverticulum. The muscle layer is not herniating outside. There is no muscle layer and hence it is called as a false diverticulum. So Zenker's diverticulum is a Pulsion diverticulum of the hypopharynx. Is it clear to everybody? Now the next one in our list is Waldeyer's ring. What is Waldeyer's ring? Now this is LKG syllabus in terms of MBBS. Waldeyer's ring. What's Waldeyer's ring? In the pharynx, the lymphoid tissue is aggregated at some specific areas in the subepithelial layer. Aggregation of lymphoid tissue in the subepithelial layer. Not just one, there are various aggregations like that and all of them together form a ring that is called as Waldeyer's ring. What are the structures present in Waldeyer's ring? Adenoids, also called as nasopharyngeal tonsil, palatine tonsils, lingual tonsils, tubal tonsils in the fossa of Rosenmuller, and finally lateral pharyngeal bands. Lateral pharyngeal bands. All these structures are seen in the Waldeyer's ring. Very good, Appolite. You have listed all of them together. That is Waldeyer's ring. Let us look into the next structure and that is Thornwald's bursa. What is Thornwald's bursa? Now this is not a very common term. It's also called as Thornwald's disease. Not very well known and that makes it important for you to learn it. It is the infection of the pharyngeal bursa. Infection of pharyngeal bursa is Thornwald's disease. Where is this bursa located? It is located in the midline of posterior wall of nasopharynx. It is located in the midline in the posterior wall of nasopharynx. What other structure is present in the posterior wall of nasopharynx? Adenoids are present. The adenoid masses are present in the posterior wall. And Thornwald's bursa is also present there. Let's study a little more about Thornwald's disease. What are the clinical features? There is persistent postnasal discharge. There is a swelling that is seen in the nasopharynx. Now, a swelling in the nasopharynx, it's very important for you to understand this concept, that any swelling in the nasopharynx will lead to obstruction of the eustachian tube. The opening of eustachian tube will get obstructed and that leads to serous otitis media or glue ear. Plus, there is also fever and sore throat. These are the features seen in Thornwald's disease. Is it clear? Persistent nasal discharge, postnasal discharge. Swelling in the nasopharynx that is obstructing the eustachian tube and causing glue ear, plus fever and sore throat which are common to infection in that area. Is it clear to everybody? Let's move on to the next one and that is Rathke's pouch. What is Rathke's pouch? It is a diverticulum from which the anterior pituitary gland develops. It is a diverticulum from where anterior pituitary gland develops. Now, why are we learning about anterior pituitary gland in E.n.t class? Because this Rathke's pouch, the embryonic remnant is seen as a dimple above the adenoids. You can clinically appreciate it as a small dimple above the adenoids. And its clinical significance is, it is a site, the tumor that arises from Rathke's pouch is craniopharyngioma. Is it clear to all of you? This is about Rathke's pouch. Let us now look into the next eponym, and that is the sinus of Morgagni. Sinus of Morgagni. What is this? There is a space between the base of the skull and the upper free border of superior constrictor muscle. And that is the space of Morgagni, also called as the ventricles of Morgagni. The space between base of skull and superior constrictor muscle. To be very precise, the upper free border of superior constrictor muscle. What are the structures that are passing through the space of Morgagni that's making the space important? Number one is the eustachian tube, levator palati, tensor palati, also called as tensor veli palatini. Levator palati is also called as levator veli palatini. Plus, there's one artery, that is the ascending palatine artery. It's a branch of facial artery. Ascending palatine artery is a branch of facial artery that's also running in the space of Morgagni. Okay. So, is everybody clear with that? Let's move on to the next one, and that is Passavant's ridge. What is Passavant's ridge? It's formed by the palatopharyngeus muscle. This palatopharyngeal muscle forms a mucosal ridge that is present in the posterior and lateral walls of the nasopharyngeal isthmus. Okay, palatopharyngeal muscle is forming a mucosal ridge where at the lateral and posterior walls of nasopharyngeal isthmus. Now, as always, why is Passavant's ridge important to us? Why should we learn about Passavant's ridge? Because while deglutition, while swallowing, the soft palate comes into firm contact with this Passavant's ridge, and this coming together of the soft palate and Passavant's ridge will seal off the nasopharynx from the oropharynx. It prevents propulsion of food into the nasopharynx. That makes Passavant's ridge important. Is Passavant's ridge clear to everybody? Okay. Moving on to the next structure, that is not an eponym but a sign that is seen, and that is frog face deformity. Where do you see frog face deformity? Anybody? It is seen in juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma. A little about angiofibroma, also called as juvenile nasopharyngeal angiofibroma. This is a tumor that is seen in adolescent males. And it's a vascular tumor that's responsible for profuse, recurrent, and spontaneous epistaxis. The presenting feature of this tumor is epistaxis, which is profuse and it's recurrent plus spontaneous. And in juvenile nasopharyngeal angiofibroma, we find this frog face deformity. Why? Because the tumor is extending up into the orbits that will lead to protrusion of eyeballs, which gives a frog face look. Okay. So, frog face deformity is seen in juvenile nasopharyngeal angiofibroma. Frog eyes are seen in another condition, not in E.n.t, but it's very, very important and a very well-known condition. Let me see who's going to answer that. Where is frog eye sign seen? A small hint, it is seen in OBG, obstetrics. Quickly answer. Wonderful, Saichan, that is seen in anencephaly. Very, very good. Frog eye sign is seen in anencephaly. Okay. Now, since we are anyhow talking about juvenile nasopharyngeal angiofibroma, let us see another sign that is seen in that, and that is antral sign or Homan-Miller sign. Antral sign, also called as Homan-Miller sign. What is the sign? In this tumor, in angiofibroma, what happens is the posterior wall of the maxillary sinus is pushed forward because the tumor is extending and spreading. So, the anterior bowing of the posterior wall of maxillary sinus is called as antral sign or Herman-Miller sign. Now, you find this as a CT finding. Okay, this is not a clinically appreciable sign, it's a CT finding. And what makes it important is this is pathognomonic for juvenile nasopharyngeal angiofibroma. Okay, JNA, yes. Is antral sign clear to everybody? Let's move on to the next one, and that is Trotter's triad. Now, this Trotter's triad is very, very, very important for any exam. So, please pay attention and listen to me. It is seen in nasopharyngeal carcinoma. This is one point that you anyhow must remember. Plus, you should also remember the three features that are seen in the triad. One is conductive deafness. Second one is ipsilateral temporoparietal neuralgia. And finally, palatal paralysis. Okay, trotter striate is very, very important, and these are the three features. Now, it's not just about mere by hearting these three features, you should understand why. Why will conductive deafness occur? Now, as I earlier also told, any nasopharyngeal mass will obstruct the eustachian tube opening. And when the eustachian tube opening is obstructed, that will lead to serous otitis media or blue ear and cause conductive deafness. Is it clear? Next, why will temporoparietal neuralgia occur? Because the fifth cranial nerve, the trigeminal nerve, gets involved in the nasopharyngeal carcinoma, and that leads to this temporoparietal neuralgia. And why does parietal paralysis occur? Because of the 10th cranial nerve. Okay, is this clear to everybody? Trotter striate. Please make sure you always remember about trotter striate. First point, that is seen in nasopharyngeal carcinoma, and then what are the three features seen in trotter striate. Okay. Next one on our list is not an eponym again, but I've put it here because, like eponyms, this word also doesn't give you any hint or clue about what disease that is. Now, for third year E.n.t. students, it must be very, very familiar. But for somebody learning it for the first time, if you look at the word quinsy, you can't predict anything. It's not giving you any hint about what it is, right? Quinsy is peritonsillar abscess. It is peritonsillar abscess. Okay. Collection of pus in the area between the capsule of the tonsil and the superior constrictor muscle, which is forming the bed of the tonsil. In between these two structures, between the capsule and the superior constrictor muscle, pus gets accumulated, and that is called as peritonsillar abscess, which is quinsy. Is this clear to everybody? And a very important feature that is seen in quinsy is muffled and thick voice. And there is a specific term for this muffled and thick voice seen in quinsy. What is that called? Put it in the comment section quickly. What is the term for this muffled and thick speech seen in quinsy? Meanwhile, I'll tell you the other features of quinsy. There will be severe pain in that area, plus fever is also observed. These are the common features, just like tonsillitis. All the other features are also observed. Muffled and thick voice is specific to quinsy, and what is it called as? Shivani, these videos are currently not available in any app. You can look at the YouTube videos, which will be regularly uploaded. And when the app is launched, you will definitely get a notification about it if you subscribe to this channel, as well as join the Telegram community. And the link to the Telegram channel is found in the description of this video. Okay? Yeah, coming back to muffled and thick speech. Highly disappointed, nobody is able to answer. It is called as hot potato voice. Hot potato voice. Able to recollect now? Hot potato voice? Or have you never heard about it? Either ways. Next one in our list is eagle syndrome. What is eagle syndrome? Has anybody ever seen an eagle? Saichand, you find a lot of lag? No, actually there is no lag in my screen also. Just try to forward your video. Maybe it was paused somewhere and that's why you're lagging 5 minutes. Try to refresh the screen and open it again. I hope there is no lag. I don't see any lag, okay? Has anybody seen an eagle ever in reality? Like a real eagle, not a picture of the eagle. What is its most prominent feature? Of course, it's huge for a bird. The size of an eagle is huge, but it's also known for its sharp beak. Yes, the beak of the eagle is very, very sharp, and that makes eagle a dangerous bird. Yes. So, eagle syndrome is elongation of one sharp process of the skull. And what is it? It is elongation of the styloid process, as correctly told by Samana Shetty and Saichand and Appellite also. Elongation of the styloid process is called as eagle syndrome. Now, when you look at the pictures of the skull, the styloid process appears as one, open-ended structure. We hardly bother about it. I mean, even if it elongates, becomes short, big, who cares? That's how it appears when you look at the skeletal picture. But I mean, imagine it in reality with all the muscles surrounding that area, all the vital structures passing through that area. If at all it elongates, and that is such a sharp structure, it can cause that effect on so many other surrounding structures, right? So that makes eagle syndrome important. I mean, that is why they've coined a term for this elongated styloid process called as eagle syndrome. Okay, so what are the features seen in eagle syndrome? There will be ear pain, definitely, and also pain in the upper part of the neck, ear and upper neck pain. Okay, plus dysphagia and discomfort in the throat. Okay. Vikas Jadhav, you're still at quinsy and peritonsillar abscess. Oh my god, is there really a lag? All of you all kindly refresh your screens once. Now with this, I complete Eagle's syndrome. And let's move on to the next one, that is Zenker's diverticulum, which we have already learnt actually. I've put that last in my list so that it will be a revision of Killian's dehiscence also. But anyhow, we have discussed Zenker's diverticulum while doing Killian's dehiscence itself. So what are the two things that you know about Zenker's diverticulum? That it is protruding out of the Killian's dehiscence, plus it is a pulsion diverticulum of the hypopharynx, and it is a false diverticulum. Very, very important. Zenker's diverticulum is a false diverticulum. Is this clear? With this, we complete all the eponyms of pharynx. We have to recap all of them with pictures. So quickly look at the pictures and I will point them out. You have to answer them for me, okay? So are all the eponyms of pharynx clear to everybody? Any doubts or any issues so far? Are the eponyms of pharynx clear to everybody? They're very few in pharynx, but nevertheless all of them are important, okay? Both from an anatomy point of view as well as from an E.n.t point of view, and also from surgery point of view actually. So what is the first structure that you're seeing on screen? What is it trying to depict? You will have to go through one more time, Appellite. I will do that for you. When you are looking at the pictures, it will be a revision. What is this that you're seeing here? Vikas Jadhav, please refresh your screen. Yeah. What is the structure that you're seeing here on screen? What is this picture? It is showing the area of Killian's dehiscence. This is the cricopharyngeus muscle and this is the thyropharyngeus part. And in between this is Killian's dehiscence. I gave a break so that you would become more active, but I see that people are getting dull after the break. No answers. What's the matter? What is the structure seen here? As I told you before also, nursery question. It is Waldeyer's ring. Okay. What is this structure that you're seeing here? You're seeing many things, but I've put it so that you can appreciate Passavent's ridge. Okay. This is the nose. Now, when you see a picture like this, it's wild. Okay, Valdez ring. Okay. When you see a picture like this with so many structures, you should first try to identify something and come backwards. Now, there are two structures that are very obvious in the structure, in this picture. Okay, either come from above downwards or below upwards. Now, if you go below upwards, this is the thyroid gland. Now, this technique applies for any picture, okay? When you see something and suddenly feel blank, you have to first try to identify some structure that you know, and with that you will get an orientation of that picture. Now, thyroid gland is being shown like that, and if you carefully observe, these are all the cartilaginous rings. So, you're looking at the picture from behind. What you're seeing is the posterior view, okay? And these structures, you can identify it as the nose. Okay, this is how you're supposed to proceed. And this is the tongue. Yes. Able to understand, appreciate? Yes, posterior aspect. Good. And this over here is the Passavent's ridge. Okay. Clear to everybody? Yes. Let me move on to the next frame, and that is this X-ray sign that you're going to see. Now here this tumor is pushing the posterior wall of maxillary sinus. And what is it? Quickly answer me, what is that? Where the tumor is pushing the posterior wall of and maxillary sinus. This wall is bowing anteriorly. Yes, very good, Aishwarya. It is Horman-Miller sign or antral sign. Good, Vikas. Why is this picture put? To show the elongated styloid process. As I told you, now in this picture, if you see, this elongation of styloid process does not seem like a big deal because you're seeing only the skeletal view. If you can imagine it with all the surrounding structures, then you can understand how serious it is, okay? Alright. What is this? What is this outpouching? It is Zenker's diverticulum. Very good, Appolite. It is Zenker's diverticulum. This is another picture from the lateral view. This is also Zenker's diverticulum. All right. Are the pharyngeal eponyms clear to everybody? Now give me a quick thumbs up if I can move to larynx. All right, let's begin. Eponyms of larynx. The first one in this is Brice sign. Let's begin with a bouncer. It's not a bouncer actually, but yeah. What is Brice sign and where is it seen? Very, very good, Vikas Jadhav. It is seen in laryngocele. It is seen in laryngocele, the external type of laryngocele. What happens is you will find a swelling, and when you compress that swelling, a gurgling or a hissing sound is produced. Basically, the movement of air will produce that sound, and that is Brice sign. In laryngocele, when the swelling is compressed, a gurgling or a hissing sound is produced. And that is called as Brice sign. So a little about laryngocele. It's a dilatation of the saccule which is filled with air or fluid or both. And the features of laryngocele are hoarseness of voice is seen. That is the main complaint of the patient. And if it's an external laryngocele, a neck swelling is also seen. Okay, that's about laryngocele. And in whom does this occur? It occurs in trumpet blowers and also in weightlifters. Basically, when the air is trying to move out of a closed glottis for a prolonged period of time, as in glass blowers, trumpet blowers, laryngocele occurs. Okay? Can I move on to the next one? Let's see a little about anatomical structures, and they are about the cartilages of larynx. Two cartilages of larynx have special fancy names, and they are corniculate cartilages of Santorini and cuneiform cartilages of Risberg. What are these two? I've put these basically to learn about the laryngeal cartilages. We have 9, 3 paired and 3 unpaired laryngeal cartilages. What are the 3 paired laryngeal cartilages? They are a pair of arytenoid cartilages. These arytenoid cartilages are pyramidal in shape. And then we have a pair of corniculate cartilages that sit on the arytenoid cartilages, and these are conical in shape. They look like horns on the arytenoid cartilage. And a pair of cuneiform cartilages that are club shaped. These are the 3 paired cartilages. Now there are 3 unpaired cartilages, and what are they? Those are very important and well known to all of you. One is of course the epiglottis, leaf shaped, and next is thyroid, and next is cricoid. Cricoid is ring shaped. Okay. So these are the cartilages of larynx. I will anyhow show you a picture that will improve the understanding. But corniculate cartilages are also called as Santorini. Now the question is, where else did we listen or come across the word Santorini? The very first chapter of ear, anatomy of ear. Where did we come across the word Santorini? and Risberg is also heard elsewhere. Nerve of Risberg. So put these two in the comment section below. Meanwhile, I'll proceed to the next one, okay? Next is Galen's anastomosis. Galen's anastomosis. Where is the seen? It is seen in the laryngeal nerves. And for that, you have to understand the nerve supply of larynx first. This also I have put so that we can revise the nerve supply of larynx. Now, in one word, if I have to describe the nerve supply of larynx, it is by the vagus nerve. Yes, but that is too simple. Vagus nerve gives two branches. One is the superior laryngeal nerve, and next is the recurrent laryngeal nerve. Yes, and this superior laryngeal nerve again divides into two branches. One is the external laryngeal nerve and one is the internal laryngeal nerve. Okay, now let us see what each of them supplies. The external laryngeal nerve supplies a single muscle. Which muscle? The cricothyroid muscle. And the internal laryngeal nerve just gives sensory supply. It has no motor action. Sensory supply to which area? The area above the vocal cords. This is the internal laryngeal nerve. And then we have the recurrent laryngeal nerve. Recurrent laryngeal nerve completes the rest of the story. That is, it supplies all other intrinsic muscles. Now, I can give you a statement. All intrinsic muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve. Okay, is that clear? And next, the internal laryngeal nerve is providing sensory supply to the area above the vocal cords. And below the vocal cords, it is by the recurrent laryngeal nerve. Is it clear? This is about the nerve supply of larynx. Now, in between the recurrent laryngeal nerve and internal laryngeal nerve, there is an anastomosis. And that anastomosis is called as Galen's anastomosis. Okay? Is Galen's anastomosis clear to everybody? A little about the course of recurrent laryngeal nerve. The left recurrent laryngeal nerve and the right recurrent laryngeal nerve have different courses. The left one is longer. It comes down till the arch of aorta, loops around the arch of aorta and then goes up again. Whereas the right recurrent laryngeal nerve comes up to the subclavian artery and then it goes up. Okay? Can I move on to the next one? The nerve supply of larynx is important, okay? All right. The next is Grizzle syndrome. What is Grizzle syndrome and why does it occur? Grizzle syndrome, I'll tell you what is Grizzle syndrome and you have to tell me where and why does it occur, okay? Put that in the comments quickly. And you have not answered the previous question also, Santorini and Risberg. Where did you hear the word Santorini? Fissures of Santorini. They are deficiencies present in the cartilaginous part of external auditory canal. Now, this is one reason why you all have to go and watch the Eponyms of ear class, okay? And nerve of Risberg, it's a branch of facial nerve. Nervus intermedius is also called as nerve of Risberg. Okay. Coming back to Grizzle syndrome, it is a painful neck and torticollis. This is the presentation of Grizzle syndrome. Why does it occur? It occurs because of atlanteoaxial dislocation. It occurs because of atlanteoaxial dislocation. This is a complication of adenoidectomy surgery. So can I say Grizzle syndrome is iatrogenic? It occurs as a complication of adenoidectomy surgery. Now what are Grad-Inigo syndrome? And one more G, Grissinger sign. Where are they both seen? Find out answers to them in the Eponyms of ear class. If you have already listened to that class, you can comment it below. Okay. And next in our list is a space called as Rinke's space. And edema is also found in that area, and that's called as Rinke's edema. Now this is a space that is present between the vocal ligament and the epithelium of true vocal cords. It's a subepithelial space. Okay, I'll write that down for you. It is a subepithelial space between the vocal ligaments and true vocal cords. Now, what will be the boundaries of such a space? Laterally, there is the vocal ligament, as the definition itself suggests. Medially, there is the true vocal cord, isn't it? Because that is the space between the epithelium of the true vocal cord and the vocal ligament. So laterally there is the vocal ligament and medially there is the true vocal cord. Anterior to this space we have anterior commissure and posteriorly there is the posterior commissure. Okay. Why is Rinke space important? For everything there is a why. Yes. And what is the answer to that why here? Why is Rinke space important? Because this is the space that enables movement or vibration of the vocal cords. The vocal cords are vibrating within the space of Rinke. Okay. And when there is irritation or misuse of voice, it will lead to edema in the space that is called as Rinke's edema. When will that occur? When there is chronic irritation to the vocal cords, as in misuse of voice, heavy smoking, chronic sinusitis, or some laryngopharyngeal reflux. In all these conditions, there is irritation to the vocal cord. Chronic irritation will lead to edema of the space called as Rinke's edema. There is bilateral symmetrical swelling of the whole of the membranous part of vocal cord in Rinke's edema. Is it clear? Okay. Next on our list is something called as Singer's nodules or screamers nodules or teachers nodules. They're seen in all these people, singers, screamers, teachers, even street vendors. Now these days, street vendors are also using mics and speakers, loudspeakers, but once upon a time, they would, scream with their voice to sell their goods. So in them also. What is the common thing that you observe in all of them? They all use their voice very, very much. And in all of them, we find misuse of voice. And what will misuse of voice lead to? As I've just told, it leads to Rinke's edema. And this Rinke's edema can progress in two directions. One, what are you all with me, able to understand? Now, Rinke's edema can either undergo fibrosis of the basement membrane. Fibrosis of basement membrane can occur, and this will get reorganized and it forms what we call as vocal nodules. Able to understand, everybody? Okay. And there is another possibility. This Rinke's edema can bleed and can neovascularize. Bleeding will lead to neovascularization. And then it will also lead to hypertrophy. And if this happens, it will cause a vocal polyp. Now, did you all understand when a nodule occurs and when a polyp occurs? So, polyp is a fleshy, bright structure because it's made up of blood vessels. A nodule appears pale because it's more of fibrous tissue. All right. So, vocal nodules are also called as singers' nodules, screamers' nodules, or teachers' nodules. Next in our list is something called as Ortner's syndrome. What is Ortner's syndrome? There are only two things present in Ortner's syndrome, and they are, one is hoarseness of voice, and the next one is cardiomegaly. Now, what is the relation between hoarseness of voice and cardiomegaly? We know the force of recurrent laryngeal nerve, right? So, in cardiomegaly, what happens sometimes is the recurrent laryngeal nerve gets trapped there. Cardiomegaly leads to recurrent laryngeal nerve paralysis, and recurrent laryngeal nerve paralysis leads to hoarseness of voice. This is about Ortner's syndrome. Is it clear? Okay. Let us move on to the next one, and that is pre-epiglottic space of Brice. Pre-epiglottic space of Brice. Why is it in our class? Because of this word, Brice, eponym. Why should we learn about it? Because this space is an important route for the spread of carcinoma larynx. Let me talk about the boundaries of this space so that you can understand it better. Now basically the epiglottis is like this, right? It is the space that is present behind the epiglottis, not behind, in front of the epiglottis, between the epiglottis and thyroid. When you look at it in pictures, it will appear as if it's behind the epiglottis, okay? I'll tell you the boundaries so that you can actually visualize the space. Superiorly, there is the hyoepiglottic ligament. Hyoepiglottic ligament. Inferiorly, there is no space present inferiorly actually, because it ends like that with the epiglottis. Anteriorly, what we have is the hyoid bone, thyroid cartilage and thyrohyoid membrane. Anterior to the space, there is hyoid bone, thyroid cartilage and thyrohyoid membrane. And posteriorly, there is the epiglottis. This is about the pre-epiglottic space of Boyce. And what is present in this? What are the contents? Very simple. There is fat, lymphatics, and blood vessels. Why is it important? Once again, because it participates in the spread of carcinoma larynx. I should take some water to avoid Rinky's edema, okay? Thank you, Appolite, for giving me this water reminder. Do you know certain schools have a water bell, just like your lunch break interval? There's something called as a water interval. They ring a bell. That's a reminder to all the students to drink water. It's to inculcate the habit of drinking water. Okay. Yeah, let's come back. Now let us look into two important X-ray signs that are seen in larynx. These are not eponyms, but they're very, very important to remember. So I've put them here. And they are thumb sign and steeple sign. Both of them are X-ray signs that you must learn and understand. Okay, let us see both of them. First, about the thumb sign. Thumb sign is seen in acute epiglottitis. It is seen in acute epiglottitis. What is the cause for acute epiglottitis? Most common bacteria involved are Haemophilus influenza and Streptococcus. This is seen in the age group of 2 to 8 years. An acute epiglottitis, a thumb sign in X-ray, we see in the lateral view. Okay, this is about the thumb sign. I'll show you a picture that will make things better. But for now, bear on with me and listen to what is this. Steeple sign is seen in the X-ray of croup. What is croup? Laryngotracheobronchitis. And this is seen in AP view. Okay, it is seen in croup. And this is caused mostly by the parainfluenza virus. Croup is caused by parainfluenza virus. And in which age group is croup seen? It is seen in the age group of 6 months to 3 years. Okay, these are two radiological signs that are very, very important in larynx. Next one is TB of larynx. TB of larynx is also not a mnemonic, not an eponym, but I've put it here because there are some very specific signs to the TB of larynx. Now, tuberculosis of larynx occurs secondary to pulmonary tuberculosis. Okay. The three special features that we see here are mouse nibbled appearance of vocal cords. The vocal cords appear as if they have been eaten by a knife, eaten by a mouse, or rather bitten by a mouse. That's called as mouse nibbled vocal cords. Okay. Next important feature that you see is turban epiglottitis. Turban epiglottis. The epiglottis appears like a turban. Why does it appear like a turban? Because of pseudoedema. Okay. And tuberculosis of larynx is a granulomatous disease. So all the granulomas will give it a cobblestone appearance. Okay. These are the three special features seen in TB of larynx. I've put them here because while answering MCQs, these are given as hints in the question for you to to point out the diagnosis towards tuberculosis of larynx. Mouse nibbled appearance, turban epiglottis, and cobblestone appearance of granulomas. Is that okay? And another special feature of TB larynx is that TB of the larynx is painful. Generally, tuberculosis anywhere in the body, TB of the lung, even TB of the ear, none of them are painful. They're all painless conditions. Anywhere TB in the body, even TB of knee or spine, anywhere they're painless conditions unless complicated by some secondaries. But TB of larynx is painful. This is one important feature of tuberculosis of larynx. I will not get teachers' nodules, Bharati. Thank you for saying, asking me to take rest though. Because why will I not get teachers' nodules, or anyone will not get teachers' nodules who are doing online teaching? Now, teachers usually raise or scream, they raise their voice to control the noise in the classroom. Now, luckily for me, I'm teaching in a silent, pin drop silent atmosphere, and I don't have to raise my voice. So let's hope I don't get teachers' nodules. Last one in our list, and that is Heimlich maneuver. What is this life-saving maneuver and where is it used? Plus, this is a very, very important term in terms of MCQs. It's being frequently asked in many, many exams, be it FMG or NEET PG. So please be mindful about Heimlich maneuver. Heimlich maneuver is done to relieve a laryngeal foreign body. To relieve a laryngeal foreign body. It's done when someone is choking, your right appolite. When someone is choking because of a foreign body that has been impacted in the larynx, you have to perform Heimlich maneuver. And how do you perform Heimlich maneuver? You have to stand behind the person and place your arms around that person's lower chest and give abdominal thrusts 4 times. At least 4 abdominal thrusts we have to give. This is how we do. Now imagine there is a person in front of me, okay? The idea behind doing this is the residual air in the lungs will go up because of your thrusting, and this gush of air will dislodge the foreign body and it will provide some airway to the person so that the choking is stopped and the airway is restored. That is the idea behind Heimlich maneuver. Is that clear to everybody? This picture should come into your mind. It's very commonly placed in hospitals and many textbooks also actually, and in some safety measures also as social awareness. When someone is choking, you will find that classical picture of 2 people, one standing behind the other and placing the arms around the lower chest and giving abdominal thrust. That is Heimlich's maneuver. Is it clear? Okay. Now, with this, we finish the eponyms of larynx. Let us quickly look at the pictures, which will serve as a recap to all of us. And with that, we can end today's session. Okay, what is the first X-ray that you're seeing? Doctors have great imagination. This is an undebatable statement, isn't it? What are you able to see here? Thumb. This is thumb's sign. And where is it seen? Where is it seen? Why is nobody commenting? Am I having a lag? It is seen in epiglottitis. Okay. Lateral view of the X-ray. What is the next picture? This is steeple sign. You can see it as a pencil tip. Now, how do you remember? Epiglottis is just one small structure seen like this, whereas croup is laryngotracheobronchitis. Laryngotracheobronchitis, it's quite long. Okay, so this is croup. You can see this entirely all the way. Let me erase it so that you can appreciate. Are you all able to see it nicely in the picture? This is the steeple sign seen in croup on AP view. Okay. All right. What are you able to see here? There is ring case edema. And what is this? It's a vocal polyp. And what is this picture? What is being performed here? It is Heimlich maneuver. Now, Heimlich maneuver is very important because when the person is choking, they cannot even call for help. Okay, that's the problem. So this person is choking and the person who's providing help is this. He has put his arms around the lower chest and he's giving abdominal thrusts. Okay. This is a picture of laryngeal cartilages. What you can see here are, this is the thyroid cartilage and this is cricoid. This is epiglottis. Behind the, in between the epiglottis and this hyoid bone, thyrohyoid membrane and thyroid cartilage and epiglottis, there is a space and that is called as the pre-epiglottic space of Boyce. Yes, this is a better picture. This is the pre-epiglottic space of Boyce. Can you all appreciate it? This is epiglottis. The hyoid bone has been, partly removed to show you the space. This is the thyroid cartilage. This is the thyrohyoid membrane. And the space between these structures and epiglottis, this space over here is the pre-epiglottic space of Boyce. That's responsible for the spread of laryngeal carcinoma. Okay. I don't have pictures showing laryngeal cartilages here. All the laryngeal cartilages Yeah, wait. Okay. In this view, you can see a few more things actually behind. Can you all see this is arytenoid cartilage? And sitting on the arytenoid cartilages are corniculate cartilages of Santorini. Cuneiform you cannot see in this view. Okay. So these are all the eponyms of larynx. We have not only completed the eponyms of larynx, with this session we have completed the eponyms of entire E.n.t. And this was actually an indirect revision of the entire subject. We have seen eponyms of ear in the previous video. Those of you who have not watched it, please go and watch that video. And in this session, we have covered the eponyms of ear, of nose and throat. I hope all of them are clear to you, and to get the notes of this session, please join the Telegram channel. It will be uploaded in a few hours. Okay. So this is all from my side. If you want any more topics, put them in the comments below so that I'll plan more live sessions for you all. And I'll come very soon with another topic from E.n.t. Until then, take care. See you all. Bye-bye.